Good afternoon, everyone. Thank you so much for joining today's webinar presented by NSEED. I will go ahead and open up with a few things to note. First, participants will be muted upon entry and videos turned off. Next, for technical assistance, we ask that you use the chat feature located at the bottom of your screens on the right-hand side. You will also receive an email approximately 1 month from today requesting feedback and impact on today's presentation. We also ask that you visit www.ncdus.org/training to view other training opportunities that NSEED has to provide. Slides from today's presentation will be made available at the end of the presentation. Also, 1 week from today, we will have this presentation available on our training center via the ncdus.org training website. We will have a 10-minute Q&A at the end of the presentation for any questions that you may have. I'll now go ahead and introduce today's speaker, Dr. Brittany Davis. Dr. Brittany Davis obtained her BE in chemical engineering at Vanderbilt University and later went on to attend Columbia University, where she received her Doctor of Dental Surgery. She has a specific interest in the interaction between oral health and systemic health. Throughout dental school, she dedicated several years researching ways in which dentists can better manage and care for patients with eating disorders. With a passion to further her knowledge of comprehensive oral and medical care, Brittany accepted a dual degree program with Emory University School of Medicine. She's currently in her 3rd year of medical school and is on track to receiving her medical degree alongside the class of 2025. I'll now turn things over to Ms. Davis. And if you can take your screen off of on record, Dr. Davis, so we can see you. Dr. Davis, are you there? I apologize, we may be having some technical difficulties. Brittany? Hello, Dr. Davis? Okay, there she is. Okay, great.
Hi, everyone. Thank you for tuning in. Sorry for the wait. So we're just going to go ahead and get started. My name is Brittany Davis, and I graduated from dental school at Columbia University College of Dental Medicine. And so today we will be going over this presentation. It's called Identifying Early Signs of Eating Disorders, Key Insight into the Dental Office. So there are many correlations between eating disorders and oral manifestations, and just the role that a dentist can play in terms of early identification and helping to get these patients treated earlier. And so there's not much the information, I don't want to say is lacking, but it's not quite as comprehensive as one would hope. And so with this presentation, I'm hoping to just kind of accumulate a lot of just up-to-date information just for the knowledge of both like oral healthcare professionals and all other associated professionals, nurses, physicians, school counselors, even just to know some things to look out for in the oral cavity. All right, and so our learning objectives for today. So first, we're going to start by reviewing the epidemiology of eating disorders, just a basic run through. Then we will differentiate the types of eating disorders. Mostly we'll be focusing on anorexia nervosa and bulimia nervosa. And then we will evaluate common associated features and medical complications. In addition, we're going to discuss the benefits of having a dental specialist involved in the care of patients with eating disorders. I will list the various oral manifestations that we may see with different eating disorders. And finally, we're going to just recognize the alternative dental interventions that exist that can maximize the long-term prognosis of patients with eating disorders. So to begin, what is an eating disorder? So an eating disorder is a behavioral condition. It's characterized by severe and persistent disturbances in eating behaviors and patterns, and it's associated with distressing thoughts and emotions. It's truly it really consumes the thoughts of those who are struggling with an eating disorder. So it negatively affects both physical health, psychological health, and social functioning, essentially all aspects of daily living. And it is associated with preoccupations with food, weight, shape, and with anxiety about eating or the consequences of eating certain foods. And so combined, when we look at all eating disorders together, they affect upwards of 5% of the population. So this certainly is a very significant disorder that we really need to pay attention to. Although it most often develops in adolescence and in young adulthood, it can occur at any age and affect any gender. So it's important that we do not only look for the development of eating disorders in young women, because we will miss quite a number of other patients who might go under the radar. Eating disorders commonly co-occur with mood and anxiety disorders. And so oftentimes you'll see these patients are also affected by depression, anxiety, things like that. And the all-cause mortality for patients with eating disorders is multiple times greater than the general population. So again, it's just critically important that we're able to kind of catch people that are showing red flags of eating disorders early, because it can truly be a matter of life or death. And so early identification and intervention are key. When we're able to identify possibility for an eating disorder order earlier on, we have higher chances of recovery the sooner we can intervene. We reduce the severity of medical complications by preventing, for example, like, I don't know, cardiac concerns from progressing for too long before things become irreversible. And overall, because of that, we're improving the long-term prognosis for these patients. And so these are the types of eating disorders according to the DSM-5. Specifically, we'll be focusing on anorexia nervosa and bulimia nervosa, mostly because those are the two types of eating disorders that there really is any literature that exists in regards to correlating it to dentistry and oral manifestations and things like that. But it is really important to keep in mind that those are not the only two. So in addition to those, we have binge eating disorder. We also have avoidant restrictive food intake disorder, other specified feeding and eating disorder, pica, and rumination disorder. So first, we're going to start by discussing anorexia nervosa. So it is a psychiatric condition characterized by persistent disordered eating habits resulting in a dangerously low weight. So according to the DSM-5, we need to meet each of these three criteria. So those include restriction of energy intake that leads to a low body weight, and a low body weight based on the DSM-5 is defined as a BMI less than 18.5, according to the patient's height and weight. Number two, the patient will show an intense fear of gaining weight and will have persistent behaviors that prevent weight gain despite being underweight. And third, there will be a distorted perception of body weight and shape, an undue influence of body weight and shape on a person's self-worth, and denial of or not denial of the medical seriousness of one's low body weight. And so within the umbrella of anorexia nervosa, there's also two subtypes, specifically restricting and binge eating / purging subtype. Restricting subtype is about exactly how it sounds, in which individuals are losing weight primarily through means such as dieting, fasting, or excessive exercising. And then for the binge eating purging subtype, a patient may engage in the above behaviors in addition to these intermittent episodes of binge eating and or purging. And so just to list a few associated features we may see with somebody that does have anorexia nervosa. So first, they're very likely to have this obsessional preoccupation with food, which may seem counterintuitive, but they may you may find that they collect recipes or hoard certain foods. They may have a list of specific foods that they're fearful of and will avoid eating. Similarly, they may have a very restricted or small list of safe foods that they allow themselves to eat. You may see somebody that overuses or just uses an excessive amount of condiments or artificial sweeteners in their foods. Likely, this patient is concerned with eating in public. And in addition, they may also have certain food-related rituals, exercise-related rituals, and a sort of behavioral rigidity. So for exercise-related rituals, you may find that somebody says that they have to walk or run a certain distance daily at the same time every day. Or if they're swimming, there's a certain number of laps that they feel that they must do each day. And for food-related rituals, it can be something such as needing to cut up any meal into very small pieces with a fork and knife before slowly eating each small piece. It's a very rigid sort of ritual. And then for behavioral rigidity, it can be a number of things, but some common ones are possibly purchasing foods only at a specific store, for example. All right, and then we're going to switch over to bulimia nervosa. And so this is kind of characterized by cycles of binge eating followed by compensatory measures to prevent weight gain. Again, we're looking at the DSM-5, and we need to meet each of these four criteria. So episodes of binge eating, which are defined as eating an unusually large amount of food in a discrete period of time, often associated with feelings of loss of control. And the discrete period of time could be, let's say, under 2 hours. Number two, inappropriate compensatory behaviors to prevent weight gain. And so that may be vomiting, but it could also include behaviors such as inappropriate use of laxatives, compulsive exercising, or fasting, or a combination of any of the above. The behavior must occur at least once a week for 3 months in order to meet the DSM criteria for bulimia nervosa. And then number four, similarly to anorexia, the self-evaluation and self-worth is unduly influenced by somebody's body shape or weight. And then looking at possible associated features that we may expect to see. So a patient may say that they eat to the point of feeling uncomfortably full or even becoming sick. Um, family or friends may notice that this person takes frequent trips to the bathrooms following meals. Parents or roommates may notice that large amounts of food seem to suddenly disappear overnight. There may be unexplained empty wrappers or food containers that can be found. And then also similarly to anorexia, this person may also have peculiar eating habits or rituals. Oftentimes they feel out of control, and they may complain of frequent GI disturbances. So chronic diarrhea, possibly chronic episodes of constipation, and also likely gastric reflux. All right, so now I wanted to do a brief review of some of the systemic long-term medical complications that we may see with patients with either anorexia or bulimia. So first, I wanted to start with the cardiovascular system. So particularly with patients with anorexia, when they've begun to lose a substantial amount of weight, essentially at some point our body, needs energy to continue on day to day. And when we're not providing enough calories on intake, our body will begin to pull from other essential organs. So in this case, we're looking at cardiac muscle atrophy. And in this picture, I included, and I hope you can see my mouse here. So this is comparing somebody of what we call a normal BMI. We can see the outline of the heart here. It's kind of almost like a boot shape, and this is about normal. And then here on this CT, this is an axial cut. So if you imagine somebody is laying flat on a bed and you've kind of sliced them like a piece of toast, that's the view that we're looking at. So the lungs on either side and the heart here. So this is about the normal size we would expect of the heart. Now in somebody that has been chronically underweight, you can see a severe difference in the bulk of the heart tissue itself. And again, looking at our CT cut here in comparison to our normal, the cardiac muscle has just decreased profoundly in size. And that has a number of complications alone. So number one, cardiac muscle atrophy. Because of the atrophy, the chambers of our heart, the volume is also reduced. So how much blood the ventricles can store and subsequently pump back out to the rest of our body, that's smaller. It's not uncommon to see these patients also have mitral valve prolapse. The mitral valve is the valve between our left atrium and our left ventricle, and prolapse meaning that the valve flaps are inverting and going backwards, and that can lead to reflux of blood backwards through the heart from the ventricle back up to the atrium, which is going the wrong way on the highway. We want the blood to be moving forward so we can perfuse the rest of our body and our limbs. And because there's muscle atrophy, a patient may also have palpitations, meaning that their heart, the electrical rhythm is going off not at the normal rhythm that we would want it to be, which is not conductive to efficient blood flow perfusing our body. And kind of as mentioned, because of all of these things combined, we'll have a decreased cardiac output, which then causes a reduced exercise capacity and fatigue, meaning that because the body is receiving less blood flow per minute, our capacity to just sustain cardiac or just cardio exercises or things like that it's reduced. And so the patient will be fatigued. And then next, looking at the GI system. And so this applies to both patients with anorexia nervosa and bulimia nervosa. So our GI system we're supposed to intake food, and then that food is processed in the stomach, put out through the intestines, and essentially comes out through the other end. However, when there are multiple episodes of vomiting or even just self-starvation, we can start to have that system becomes affected. And so we may see something called gastroparesis, which is delayed gastric emptying. So if we're looking at this picture here in our upper left-hand corner, so whenever we intake fluids and food, it should pass through our stomach and then continue on to the intestines. But with gastroparesis, because there is this delayed emptying, we're going to have a backup of the food and the substances that we put into our stomach. And so that's going to cause symptoms such as bloating, early satiety and fullness. If you can imagine, if the food that you had for breakfast if it's still sitting in the stomach by lunchtime, you're still going to feel that feeling of fullness. And then nausea and vomiting. Our stomach has only but a limited amount of capacity. And so if we are continuing to put food in when there really is just no space to accommodate, then we certainly will have the feeling of nausea, but very easily can vomit unwillingly just because there's this backup. And so we can also see things like chronic constipation, elevated liver enzymes, gastroesophageal reflux disease, dysphagia, and diarrhea due to villus atrophy. And so looking at this picture in the bottom left, I know it says celiac disease. We could kind of just pretend we're not looking at that, but I really liked the image itself. So our intestines have all these microscopic villi. So when we're passing substances through, these little tendrils will be able to, it has the increased surface area, so that way we can absorb the nutrients from the food that we're eating. But when we have somebody who has chronic malnutrition, for example, we can actually see blunting of those villi here. And so they become very flat. The surface area overall is greatly reduced when compared to normal. And so our body becomes less efficient at absorbing those nutrients that we're supposed to be giving it. And because of that, we see possibly diarrhea. So the foods, you put it in and it's coming right back out. We're not really able to absorb as much as we would have before. And then moving on to the pulmonary system. So again, similar to our cardiac muscle, when we have this chronic malnutrition, our body's going to start pulling from inappropriate areas to try to get that sort of energy intake. And so we may see wasting of the respiratory muscles secondary to starvation. So when we have this wasting of the muscles, we're going to have a decreased pulmonary capacity. Our lungs physically won't be able to take in as much air with each breath as it would have before. And because of this, we have a decreased capacity to maintain aerobic activities. And then finally, we'll have dyspnea, which is having difficulty breathing, especially with anything that requires like an increased aerobic work. And second, there is a notable risk for aspiration. And so aspiration is when, food that we're trying to put down into our esophagus may be regurgitated back up and instead go down our trachea into our airways. And so regurgitated material is at highest risk for aspiration following self-induced vomiting. However, when somebody has had this chronic sort of pattern of self-induced vomiting, their pharyngeal muscles do become weakened. You may even see dysphagia, which is like difficulty with swallowing due to protein malnutrition. So we also may see this with patients that have anorexia nervosa. And so you're at higher risk for unwanted regurgitation of food. And then that food then getting down into our airways and into our lungs can cause aspiration pneumonia, which can cause a very severe infection. And the picture that I included here, I just wanted to show, so these are more or less kind of opened airways, although we do see a little bit of consolidation in our lower left. Here we have a lot of haziness within the airways, and that's indicative of, or likely can be indicative of an aspiration pneumonia. So these are our chest x-rays. And then here we're looking at a CT scan again. So assuming the patient is lying flat with their feet pointed towards us, and we've sliced them like a piece of toast, we can see the consolidation here for some aspirated material in our right lung. And then particularly on this slide here, on our left side, and keeping in mind right and left are switched on these images, or they're reversed. Particularly here, we have a lot of aspirated material, and so risk of infection, possibly sepsis, is of great concern. All right, and then kind of finishing up with some systemic effects. So we also have hematologic effects that we'll see. And so with chronic malnutrition, our bone marrow functioning will be impaired. So we can often see that with patients with anorexia nervosa. And our bone marrow is responsible for producing mature red blood cells. And so we can see a decreased count of any of the three main blood cells. So anemia, which is a lowered red blood cell count, can also be seen as a low hemoglobin count. So these are the cells that are physically carrying the oxygen molecules throughout our body and distributing them to our muscles. Leukopenia, which is a low white blood cell count. These are the blood cells that are helping us to fight infection. And so having a leukopenia makes somebody more susceptible to having, number one, an infection, but number two, an even more serious infection, because their capacity to fight it off is also hindered. And then third, thrombocytopenia, which is a low platelet count. And so with low platelets, platelets are what we need to be able to, form blood clots. And so when that count becomes too low, you can start to see spontaneous bleeding, excessive bruising, things like that. All right, so now we are moving on to the reason you all joined us today, and that's the role of the oral healthcare professional, oral manifestations associated with eating disorders. So there are many advantages that exist in regards to dentists becoming more involved with the interdisciplinary care of patients with eating disorders. And so one of the biggest advantages is that dentists, we have multiple different specialties, and we see patients of all ages, and kind of remembering that eating disorders may manifest across a whole, at any age, essentially. So with pediatric dentistry, we're seeing kids from as young as 6 months, which hopefully shouldn't be a concern, but upwards of like 20, 21. With orthodontics, classically, orthodontists are seeing patients that are around like teenage years, although braces are becoming more popular in adults as well. General dentistry, of course, sees patients typically from 21 onwards, kind of through the rest of life. Prosthodontics are a type of dentist who make prosthetics. So if you think about things like dentures, and so they're often working with an older age demographic. And then oral surgeons just see patients across the board for a whole number of different reasons, whether it's maybe a 17-year-old getting their wisdom teeth out. It could be a 12-year-old that has like a benign cyst in their jaw. It could be a 70-year-old that has osteonecrosis of the jaw, secondary to like bisphosphonate treatment. So all that to say, across the multiple specialties involved in dentistry, we certainly see people of all ages. It's also very helpful that ideally people have pretty frequent checkups with the dentist. For somebody that's got pretty healthy oral health, or oral health regimen, and is low risk for cavities, we recommend seeing the dentist every 6 months. And for somebody that needs a little bit more aggressive dental care, we may see follow-up as early as every 3 to 4 months. And so comparing that to possibly somebody's primary care physician or practitioner who you may see annually, it's nice that a dentist potentially can give that sort of frequent recall and also kind of keep track of how this patient is doing and over a long period of time. And then maybe most obviously, dentists are known for their comprehensive oral exams. And so when we keep in mind the fact that oral manifestations of eating disorders can be among some of the earliest presenting signs, it's just absolutely critical that somebody's able to note those signs and be able to start the process for intervening. And so dentists, are going to be the ones who are going to have our fingers up in somebody's mouths and not be quite so afraid of getting bit, things like that. But we'll be able to notice the subtle signs. And then, ideally, dentists have these strong, trusting patient relationships. It is a pretty intimate space, close, we're face to face with our patients. And so we try to develop pretty good, just like casual relationships, and hopefully a patient would feel comfortable enough to open up with us with something as like difficult to talk about, like a possible eating disorder, or even just poor relationships with food, or poor thoughts of like their own weight, things like that can be difficult to speak about otherwise. And then kind of similarly, dentists can be among the first providers that encounter an undifferentiated eating disorder patient. So somebody that has these signs of a possible eating disorder, but has not yet been diagnosed. And finally, there are dental interventions that we can implement that will improve the long-term oral health prognosis for our patients. So aside from just picking up on these red flag symptoms and appropriately referring our patients to get additional help, there are also different interventions that we can implement as well that will help their oral health. Okay, and so now I want to do just a very brief review of dental anatomy, as it'll be relevant to understanding some of the presenting symptoms further on. And so starting with our outermost layer of the tooth, that's what we call enamel. So we're looking at this sagittal cross-section of a tooth here. The enamel is this outer white layer. Fun fact, it is the hardest tissue in the body. Excuse me. And enamel is made up of a crystalline complex of calcium, phosphate, and water. And together, those mineralize to form a molecule we call hydroxyapatite. So enamel is, the part of the tooth that when we see each other smile, that's what we're looking at. So now the enamel is protecting this softer layer called dentin. This is a middle layer of the tooth. So it's less mineralized, it is softer, and it's also responsible for transporting nutrients from the innermost blood vessels to these outer, harder tissues. So it's made up of a network of microscopic tubules that transport the nutrients, but it also transports sensory input. And so the dentin is what's responsible for people who have sensitivity to hot, to cold, to sweet foods, to acidic foods, or even to air. Some of you may notice that when you're at the dentist and we blow a little bit of air over your teeth, that it may feel sensitive, and that's thanks to the dentin there that's providing that sensory input. And so the clinical correlation being that if our enamel begins to wear down and the dentin becomes more exposed, less protected, that's why we're going to have this increased sensitivity and this increased discomfort. And then finally, the innermost layer is called the pulp, or the pulp chamber. So looking at the picture, that's right here. Each individual tooth has a pulp chamber, and that's where we find nerves and blood vessels. So they enter through the root tip of each tooth and come in, and then that's where they kind of trade off their nutrients, hand it over to the dentin, who disperses it accordingly. So the pulp is the space where our tooth is communicating with the rest of our body, essentially. So that's kind of where the concept of a root canal comes from. If we get a cavity that spreads from the enamel, the outermost layer, and it burrows in, a cavity, keeping in mind, is a bacterial infection. Once that bacteria hits the pulp, now they've got a highway out through the root tip into the rest of the body. And so that's when a root canal means cleaning out the pulp chamber and disinfecting it. So that way we stop that infection from spreading into the jaw or further. All right, and so acid solubility is a big topic in regards to dentistry and its associations with eating disorders and how they manifest. So for a bit more background information, our teeth have this critical pH for mineral dissolution. So for enamel, that pH is going to be 5.5. So anything that is lower than that, so pH of 5.5 or less, is that's the critical point in which we can start to demineralize that crystalline structure that we talked about of the calcium, the phosphate, and the water, the hydroxyapatite crystals. And then dentin is even more sensitive. So we have a critical pH of 6.8. So that's why it's so important for us to maintain a thick, healthy outer layer of enamel, because our enamel at least is a bit more resistant to an acidic insult. So there are multiple different ways that our teeth may be introduced to acids. So we have extrinsic acids. So that can be things like food and drink, particularly citrus fruits, lemons, things like that. And then for drinks, I mean, there's a whole host of, soda, energy drinks, coffee, lots of things are pretty acidic. And so those are extrinsic. They're coming from the outside that we're putting into our body. And then intrinsic acids, things that are coming from the inside, bacterial acids. So there's a colony of bacteria that lives within all of our mouths naturally, and they feed off of carbohydrates, so the sugars that we eat. And as they are going through the fermentation process, they are outputting acids, particularly lactic acid. And so the bacteria housed within our mouths are secreting acids that can contact our teeth. And then finally, and relevant on the topic of eating disorders, we also have reflux gastric acids, which also may present as GERD. So anytime that we've got some sort of reflux, that is a stomach acid that's coming up to our esophagus and then contacting our teeth as well. And so our body's single most important protective factor to prevent against an acid insult is our saliva. Saliva provides several different mechanisms to protect our teeth. So number one, and most basic, it provides a physical barrier against direct contact. So saliva, assuming that we don't suffer from dry mouths, will coat our teeth and provide just a little bit more, a little bit of separation between the acid directly touching the enamel to an extent. Saliva also serves as a very important buffering substance. So saliva's pH is 6.7. So still a little bit more basic than even like the critical pH for enamel, about the same as dentin. But all that to say is that saliva, when it contacts an acid, let's say we drink a Diet Coke, it can help buffer and neutralize the acids in that drink. And then saliva also is an important component in washing away carbohydrate substrate. And so kind of as we mentioned previously, that bacteria feed off of the sugars that we eat, any sort of carbohydrate substrate. Saliva has enzymes that will break down the carbohydrate, particularly amylase is one of the main ones. And then it physically washes that substrate away. So that way we're kind of depriving the bacteria of food that it can feed off of to generate those secreted acids. And similar to how it washes away carbohydrates, saliva is also washing away the secreted acids that are output from the bacteria. And then finally, saliva carries within it calcium and phosphate, which are the building blocks we need to create that crystalline structure within our enamel. And so as calcium washes over, or as saliva washes over our teeth, it is replacing the lost calcium and phosphate that come from the acid demineralization process. So one of the biggest things that I want to stress is that weakened enamel can remineralize. So what I mean by that is, let's think of an enamel as like a wooden fence that is surrounding our house. If you lose just one or two fence posts, maybe a storm knocked them out, those individual fence posts can be replaced. We can bring in new wood and replace that part. However, if a whole section of the fence gets knocked out and there's like a gaping hole, the enamel cannot regenerate. And so we can sustain an acid attack and demineralization up into a certain point. And sorry, my cat would like to say hello. Up into a certain point, but once the acid has destroyed whole sections of enamel, it will not grow back. All right, and so as dentists, we're able to recognize different patterns for acid erosion. All erosion is not created equally, and it does not look the same. So first, we're just going to review extrinsic acid erosion. So kind of keeping in mind the extrinsic acids we were discussing. So consumption of acidic foods and drinks, which are things like sports drinks, sodas, citrus fruits, anything that we're putting into our mouth, we're going to see this pattern of extrinsic acid erosion. So oftentimes we may see this pattern with patients that have anorexia. Something like sucking on lemons can be a common sort of behavior, and that will most certainly lead to a notable pattern of erosion. And so the erosion we'll see will be on the buccal or labial surfaces. Buccal meaning cheek, and so the cheek side or the lip side of our teeth facing outward, and then occlusal surfaces, which means the biting surfaces. When we close our teeth together, the two ends that touch when we close our teeth together are occlusal. So buccal and labial, the outer surfaces of the teeth, and occlusal, the biting surfaces. And it will cause what looks to be it's been described as a dished out appearance. And so I'll pull up some pictures here. So this is extrinsic acid erosion. So particularly on our upper teeth, we can see, so the outside, we're standing outside of this patient looking in at their smile. We can see notable acid erosion here. Here, pretty much anywhere we're showing this discoloration, a little bit of pitting here, and certainly it's prominently here as well. And the bottom is also affected. So food and drink that we're bringing in from the outside that we're eating or drinking can erode the outer surfaces. And here are some more examples. So this is looking at the upper arch of the teeth from beneath. So we can see along these incisal edges that we've also got this notable erosion. These are the occlusal surfaces or the biting surfaces, as I mentioned. And so we can see these pits here all throughout the molars, on some of the premolars here. So our biting surfaces will also show this erosion. And then finally, again, looking in at somebody's smile, we can see some more erosion on these outer surfaces, buccal and labial surfaces. Enamel does taper near the incisal edge, near the tip of the tooth. And so that's the first part of the tooth that will start to fracture as it's eroding. It will become very translucent, which you can see along this rim because the enamel layer is becoming so thin, and then at some point it will just kind of crack off and fracture. Okay, and so I would like to contrast this with intrinsic acid erosion. And so intrinsic erosion, particularly we're looking at gastric acid that has contacted the teeth. So that could be due to self-induced vomiting, which we can see with bulimia nervosa. We can also see it in anorexia, the binge eating purging subtype. But it is important to keep in mind that we may also see this pattern of erosion with somebody that has severe GERD or nocturnal reflex. It's going to look very similar. And so the difference in look, there's a term that we it's called perimylolysis. And the acid erosion causes this smooth, glossy appearance, specifically on the lingual surfaces of the teeth. So whereas the buccal and labial surfaces were the outer surfaces facing our cheek and our lips, the lingual surfaces are the inner surfaces of our teeth facing our tongue. And primarily we're going to see that it's affecting these lingual or palatal surfaces, especially of the upper, our upper arch and our front teeth, so our upper anterior teeth, in addition to occlusal surfaces, upper and lower. But if you can imagine if, you were sick and you had to vomit, if you just kind of imagine that sort of pattern of regurgitating food, that's why we see erosion on the inner surfaces, especially of our upper teeth. And I do have some pictures as well. So I apologize that it's a little bit blurry, but what we're looking at here, if you can imagine that you are standing on the patient's tongue and you're looking outward. So these are their upper teeth, their upper incisors. So this outer rim is enamel. So if you were looking at them from the outside, their smile would look relatively normal, but from the inside, the enamel is completely gone. That's why we see all of this yellow dentin. The enamel is completely eroded away. And it almost looks like the tooth has been sliced coronally. And I have a few other pictures that might make it a little bit more clear. So again, from the outside surface, the teeth look healthy and white. There's plenty of thick enamel, but from the inside, we can see that, the tooth should be white throughout. So we can see that the inner surfaces of each of these teeth has severely been affected by acid erosion. And same on this side. Enamel is white, dentin is yellow. So that's why we see progressive yellowing whenever we have progressive acid erosion. And so to correlate clinically, erosive effects can be seen in teeth as soon as 6 months, which is important because if we are trying to intervene in patients that are developing disordered eating habits, we want to intervene as soon as possible. And 6 months is a relatively short amount of time to begin to see some of the effects of somebody who does have any sort of purging behaviors, and kind of make note and maybe have a conversation with them and see if we can, try to halt those behaviors. Now, patients that have, chronic purging behaviors, they will come in complaining of sensitivity to hot, cold, touch, to airflow, which makes sense, keeping in mind that the dentin, that inner layer or the middle layer of our teeth, is what transports that sensory input. So with it being so exposed due to the acid erosion, the sensitivity also becomes just progressively unbearable almost. And so with acid erosion, how we saw in one of the pictures that the incisal edge, the tip of the tooth, was starting to fracture away. That's what we call progressive shortening of the clinical crown. So clinical crown just meaning the amount of tooth you can see above the gum line. So that will start to look shorter and shorter as it's eroding away. And when that happens, we can see things such as an anterior open bite. And I'll show pictures of each of these as well to make it a little easier to understand. We may see compensatory eruption of the lower teeth, loss of VDO, which is a vertical dimension of occlusion, and then high set restoration margins. A restoration is a filling. So like a silver filling, amalgam, or like a white filling. And then, of course, with progressive erosion, we start to see subjectively poor aesthetics, which can lead to low self-esteem and ultimately just really harm somebody's mental health and kind of keep that vicious cycle going. So first, to show you, and I apologize, the quality of this picture is certainly not great. It was one of the few I could find, but an anterior open bite. If you imagine when you smile, your upper teeth overlay your bottom teeth a little bit. But here, because we've had so much erosion of these top teeth and they've become so short, now when the teeth are closed together, there's a gap. And that's what we call an anterior open bite. Now, some people are born with or just naturally have a sort of gap like that. That's typically corrected by orthodontics, but this is an anterior open bite that has just developed secondary to the erosion. It's not a normal, or it's not this patient's normal. It's acquired. So compensatory eruption. So on the left here, we have a picture just to demonstrate what an average normal smile looks like, how we have the upper teeth that are overlapping. And so if we're looking at his smile curves upward. And then if you look at where his teeth overlap, that curve also goes upward. So it follows the same curve as our smile. When we have, alternatively on the right side here, when the upper teeth have eroded and become very short, our bottom teeth can actually supra erupt. So our lower teeth are going to kind of come out of the gum line even more, trying to essentially meet their neighbors so they can still contact. And so when that happens, we might see something called a reverse smile line, excuse me. So whereas the curve of these teeth goes upwards and it follows the curve of his smile, the curve of these teeth actually goes downwards, the opposite way of the smile. So that's what we call the reverse smile line. And then VDO, vertical dimension of occlusion. So it's trying to stay simple and not make it too complex. Our teeth support our jaw, and it kind of maintains a certain distance between our maxilla and our mandible, which is this orange arrow here. When our teeth become severely eroded and shorter, now we're decreasing the distance between our maxilla and our mandible. And so I put this picture here because it looks similar to somebody that has dentures, for example. If you've ever seen somebody that has upper and lower dentures and then they take them out for the night, you can see that their face has a little bit more of a sunken look, a little bit more compressed. And that's that same sort of presentation can present with patients that have severe acid erosion of their teeth as well, because we've lost that sort of height support from the teeth. And so here also showing kind of the progression of, the full height of the teeth. And then as we start to lose it, we kind of lose that support in it kind of to fill out our face. And so it does give in the appearance of an older age, which again can really contribute to self-esteem. And then finally was the high restoration margins. So a restoration is a filling. So for just easy visuals, I chose some pictures of silver fillings, also called amalgam. This is what a normal filling looks like. You can see, so each tooth has cusps and valleys, and the filling should follow the curvature nice and easy and should terminate just flush with the tooth. When we see somebody that has severe erosion, the tooth itself has begun to worn down. The filling has not. It's made of metal. And so that's why we see it protruding much higher. This is the original height of the tooth. And this is the difference to how much it's worn down by acid. So again, just These are visually some clues that we can use in dentistry to kind of make a note that, something's going on here. So we need to have a longer conversation with our patient and try to get to the bottom of why we're seeing such prominent acid erosion. And then continuing on with additional oral manifestations that we may see. So mucosal trauma is certainly a common complication, and that can be due to repetitive episodes of self-induced trauma. So if somebody is inducing themselves to vomit, maybe they're using fingers or a toothbrush or the back of a hairbrush, having that item hit the hard and soft palate repetitively is going to cause some blunt force trauma. And so first we're going to see pain and erythema or redness in the area of our palate. However, if there's continuous trauma to the same isolated spot, we may develop ulceration of the area. The tissue begins to break down. You may also see a hematoma or like a bruise collect in that space. And then also we may note some trauma to the throat and to the esophagus. So with repetitive episodes of emesis, it will certainly cause irritation and inflammation of the esophagus. And so you may hear somebody say that they've got this constant sore throat. You may hear that they have a hoarse voice. That's also due to the irritation and inflammation affecting our vocal cords. And we also might see somebody develop a difficulty swallowing. And so with chronic emesis or vomiting, it can progress to esophageal ulcers and bleeding, and then as serious as esophageal rupture, which is a medical emergency. And this, not so much the esophageal rupture, but if a patient starting to notice like red or blood in their vomit, that's when we do begin to worry that maybe they're developing an esophageal ulcer, and even that does still need pretty immediate medical attention. And so here are just a few pictures of what some trauma can look like. In the middle here, we've got the hematoma, that bruising to the palate. On the left, the color makes it a little bit harder to see, but this is a pretty sizable ulcer in the middle of the palate. And then here on the right side, again, we have an ulcer that's starting to progress to the bone, as that area of the palate is just not being allowed space or time to heal, in addition to repetitive acid contact, which of course also is not helping the healing process. So xerostomia is also a very common side effect we may see with patients that have eating disorders. So xerostomia is defined as low salivary flow. And so when we have less saliva in our mouth, we are at higher risk for caries, which is another word for cavities. Kind of as we discussed previously, saliva is really important in regards to washing out carbohydrate substrate. So that way we're depriving bacteria of the food that they flourish on, and also washing out bacteria itself. With low saliva, the bacteria is really allowed to kind of set up shop and settle and just kind of, flourish and secrete acid and start to burrow into our teeth, which is really what this picture is showing, how the bacteria will settle and then eventually begin to secrete acids and burrow deeper and deeper into the tooth, which is a cavity. And then also when we have low saliva flow, we are at higher risk for acid erosion because we're losing that buffering capacity that we spoke about earlier, with saliva having that pH of about 6.7. And then also we're losing the benefit of replenishing our electrolytes. So the calcium and the phosphate that saliva will bring to the teeth to help it remineralize. So all of that becomes compromised. So there are several causes for low salivary flow. So first, we may see a change in salivary gland function that's secondary to chronic binge purge cycles. Low salivary flow or xerostomia is also a known side effect or a known possible side effect of SSRIs, which are selective serotonin reuptake inhibitors. It's one of the first line antidepressant medications. It's very commonly prescribed to patients with eating disorders. I mean, patients with a whole abundance of mood disorders, but also patients with eating disorders. And you may recognize it by the name. So Prozac or fluoxetine, Celexa, citalopram, and Zoloft or sertraline. So something to kind of keep in the back of our minds and also educate our patients about as well to look out for. And then being dehydrated overall will cause a low salivary flow. So dehydration may result from fasting. It can result from self-induced vomiting because we're losing fluids if we do not replenish them. It can come from intensive exercise, sweating off a lot of fluids, and inappropriate use of laxatives or diuretics. And so another oral manifestation is called parotid gland hypertrophy. So our parotid gland is the largest of our salivary glands, and it's located, you can palpate it just anterior to our ears. Technically, it's located in the retromandibular fossa. And with repeated stimulation, and by repeated stimulation, I mean self-induced vomiting, we can see this sort of transient swelling. So the swelling will begin on average around 2 to 6 days following a binge purge cycle. It will be soft to the touch, and classically it is not painful. And it creates this wide sort of square appearance to the jaw. The prevalence is debated a bit, but literature says about 10 to 50% of people who have these chronic binge purging cycles can develop at least one episode of parotid gland hypertrophy. And keeping in mind that it's transient, so it will swell up and then resolve on its own without intervention after a few days, and then can recur during that cycle. With early intervention and discontinuing the behavior of self-induced vomiting, it's overall a reversible change. The swelling will go back down as normal, and we don't expect there to be any like residual swelling that we'll be able to note. However, if the binging purging cycle goes on for an extended duration of time, and the exact quantity of time is not quite known, but let's just say over the course of years, that parotid gland hypertrophy will become permanent, and it will lead to a permanent deformation of the face. And so again, just kind of showing how important it is to intervene as early as possible to prevent these sort of long-term complications. And then again, some more pictures. So this is kind of what it looks like. The parotid gland is anterior to our ears, and it gives this boxy sort of appearance, very soft to the touch, not painless. It will recede on its own unless the behavior continues for an extended period of time, after which it can become a permanent feature of the face. And then quickly, I wanted to go over some different nutritional deficiencies that can result from malnutrition being seen either with anorexia or bulimia, and the different oral effects that those vitamin deficiencies have. So with a vitamin A deficiency, we can see salivary gland atrophy. With a vitamin C deficiency, which is also known as scurvy, we start to have compromise of the periodontal ligament, which is the ligament that holds our tooth. It anchors it to the bone. We can also see gingivitis and spontaneously bleeding gums. And so this picture here kind of shows this is what healthy gums look like. They're pink, they're not inflamed. With gingivitis, they're swollen, they're painful, they're red. This is a pretty severe case of gingivitis. And then also spontaneously bleeding gums. Some people may note that their gums bleed every time that they brush their teeth, but also sometimes unprovoked. And so with a vitamin D deficiency, similarly, we can see gingival inflammation, but we can also see the development of periodontitis. So periodontitis is when we start to lose the bone that the tooth is anchored in. So in a normal tooth here, we've got a sufficient amount of bone wrapping around its roots. And as periodontal disease progresses, that bone begins to wither away and we lose it. And it can get to the point where the tooth is no longer housed in any bone and it will be extremely mobile or wiggly, and a person can just pull out the tooth. So this is kind of an example of what that could look like. We're starting to see the roots of all of these teeth because the bone that it previously was encased in has now started to atrophy. Prior, we're only supposed to see this part of the tooth, the clinical crown. We should not see any part of the root itself. And then with B complex deficiencies, some people develop a symptom called burning mouth, which is exactly as it sounds. It can also cause cracked lips, oral ulcers, and angular cheilitis. So angular cheilitis is this sort of cracked, raw area at the corners of the mouths, and here, the cracked lips as well. With a calcium deficiency, we can see decreased alveolar bone density, which makes sense. If we think of any of the bones in our body, a deficiency can cause like an osteopenia or an osteoporosis. Similar concept for the mouth as well. So alveolar bone is our jawbone, or at least the portion of our jaw that is encasing the teeth. And so this is just kind of an anatomical picture to show kind of like a cross-section of the alveolar bone. So from the outside, each tooth is encased in bone here, and then at a cross-section, you can see how each root is truly buried in the bone, and here also showing a similar picture. And so we can lose density with calcium deficiencies, which will make us more susceptible to periodontitis. That bone can wither away easier because there's less of it. And then that leads to mobile teeth that, have the potential for tooth loss, falling out. With an iron deficiency, we can see, excuse me, this thing called pica. So it's a craving for non-nutritional substances. And I include it here as an oral symptom because commonly people who develop this symptom will have an intense craving for chewing ice, which is certainly not good for the teeth. So this is kind of just really just a little chart to show some of the different things that people may crave when they have pica. So geophagia is eating or having a craving for like dirt or like clay-like or earth-like substances. And then pagophagia is that compulsive craving to chew on ice. And so it's very harsh on the teeth. It can cause like cracking of the teeth. It can also cause increased sensitivity. So somebody that's developed pica may have some oral sequela as well if it's not addressed quickly enough. And then finally, a zinc or copper deficiency can increase enamel acid solubility. And that just kind of comes full circle to everything that we've been talking about with enamel acid erosion. And so just being more susceptible to that, cavities being able to progress quicker. It really just makes everything worse, essentially. And then finally wrapping up on oral symptoms, oral candidiasis is also known as oral thrush. So within our mouths, we all have native bacteria and fungi that live in our mouths. So Candida is a classic yeast. However, when somebody has either malnutrition or they've had multiple episodes of binging and purging, we can disturb the sort of balance of bacteria and yeast in our oral cavity. And if the Candida species becomes too prominent, that's when we see this sort of presentation of oral thrush or candidiasis. And so it's classically known as like a white or yellow spots. You can see it on the tongue, in addition to the inner cheeks, the tonsils, the gums, the lips. It creates like this overall soreness in the mouth or a burning sensation. Typically, it will bleed a little bit if you try to scrape it off, and it can cause naturally a pretty bad taste in the mouth or even a loss of taste. And so overall, our goals for dental intervention for patients that are showing habits of disordered eating patterns, there are a few goals that we want to hit. So number one, we want to reduce the frequency of oral acid exposure. We want to help enhance salivary flow. We want to neutralize acids in the mouth, aside from our native saliva. We want to support enamel resistance to demineralization, or even encourage remineralization of enamel that's had some amount of acid damage. We want to minimize abrasive oral hygiene habits. We want to preserve remaining tooth structure. And also we want to delay complex restorative treatment until the causative behavior is better controlled. The reason for that being that if somebody needs a series of crowns on their teeth, those crowns will fail within a relatively short amount of time if they're exposed to excessive acids from like self-induced vomiting. And so we don't want to proceed with comprehensive treatment when we know that we're not setting the patient up for success. So we want to kind of do temporary restorations or fillings until a more appropriate time. And so for some in-office considerations or in the dental office, fluoride is our friend. Fluoride actually incorporates into the hydroxyapatite crystalline structure of enamel, and it makes it more resistant to acid demineralization, and it also makes the remineralization process faster. So fluoride in our water is one of the best inventions in dentistry. I know it can be a little controversial sometimes, but we love it. So we can do things like an in-office topical application of fluoride. There are some prescription daily rinses we can offer, and then we can even make some custom trays for at-home gels for people who need that extra sort of boost. We also have several desensitizing agents that we can use, especially when we're doing fillings, to help with that hot and cold sensitivity. Kind of as we spoke about before, we want to lean more towards temporary restorations until the causative behavior is better controlled. And along the same lines, doing conservative treatment. We can also prescribe artificial saliva, and then we're certainly going to want to do more frequent recall, not only just to assess just the oral health overall, but also checking in with these patients and saying, you know, have you been able to follow up with this referral, or, you know, how are you doing yourself mentally? And there are several harm reduction suggestions that we would offer to our patients. And so we would ask, if possible, that they decrease the intake of acidic food and drink, kind of just educating them on what are some of the most acidic foods and drinks. Using a straw when drinking acidic fluids, it helps kind of puts the fluid past the teeth a little bit more straight down the throat. So it helps preserve the teeth a little bit better. We would recommend swishing with water or any sort of alkaline solution after an episode of vomiting, and that's going to help neutralize the acids. And then a big thing is refraining from brushing your teeth for at least about 30 minutes following the episode. Some people feel inclined to want to brush immediately after, which makes sense. However, when our teeth are in a sort of weakened state following immediate acid exposure, brushing with a toothbrush can be abrasive and weaken it even more. And so that's why we want to wait at least 30 minutes for our teeth to remineralize a little bit before using any sort of physical sort of insult against the teeth. And sipping water throughout the day also just helps with keeping acids neutralized. minimizing carbohydrate heavy snacking if possible. Again, carbohydrates are the substrate that our oral bacteria thrive on. Using sugar-free gum to stimulate production of saliva. We already discussed all the reasons why saliva is one of our best friends, and particularly sugar-free gum. Chewing sugar or gum with sugar in it is, while it stimulates saliva, it's also giving carbohydrates, which we want to try to avoid. And then brushing technique is critical. So using soft bristle toothbrushes. I know some people love the hard bristles because they feel like they can feel themselves brushing off the plaque, but it is abrasive to our enamel, which we want to protect at all costs. So soft bristles using gentle circular motions. So no sawing horizontally back and forth, just gentle circular motions. And then flossing daily just helps to reduce like plaque buildup on the surfaces of our teeth where our toothbrush bristles cannot reach. All right, and then ultimately, just in dentistry, the biggest goal is that we want to begin practicing interdisciplinary care. So that's going to involve thorough documentation of all of our exam findings, especially when it comes to documenting the progression of some of these oral symptoms that we discussed. We want to inquire about our patients' eating patterns, their relationship with food, having these tough conversations, not shying away from them. We can even use the SCOFF questionnaire if there's a higher suspicion for a possible eating disorder, just to help us as dentists and hygienists kind of have a threshold for should we refer this patient or, kind of pursue heightened care if we're worried about their eating habits. And then, of course, always having open and compassionate dialogue, being non-judgmental at all times, referring our patients so that way they can initiate intervention as early as possible, trending the changes that we see in our oral findings, in addition to bringing them in frequently with that 3 to 4 month recall, and maintaining an active interest in the progress of their interventions and overall well-being. We do pride ourselves on having a strong, close relationship with our patients, and so we shouldn't shy away from letting it show and just showing that we do care about them, even if it's regarding something outside of our scope per se, and just seeing if there's anything else we can do to help support them in their journey to recovery. And so here's a long list of references I have, and that's about all I have for you all today. So if you will be so kind as to scan this QR code, there's a short evaluation, just to help kind of review and give me some feedback. I would really appreciate if you're able to do that. And also if anybody has any questions that they want to put in the chat or unmute if you'd like, you're more than welcome to.
Hello, everyone. Thank you so much, Dr. Davis. Like she mentioned, we ask that you put any questions in the Q&A box. I know we went over a few minutes, but we welcome any questions that you may have. If we're unable to get to them, we can get those sent
and
out
also,
via
if you have
email
any
at
questions
the
that come up
end.
later, because I know asking for questions on the spot is always difficult, you're more than welcome to email our coordinators, Courtney, Lachelle, anyone with your questions, and they'll pass them along to me, and I'm more than happy to get back to you and give you a response. Or if there's any resources that you would like me to share, any of my just like research articles that I referenced, I'm also happy to pass along those as well.
And we'll definitely share her email when we send
I'll
out
stay on this
the
link at
follow-up.
least for the next like 10 minutes or so for any questions that do pop up. So just feel free to, shoot it out if it comes. And otherwise, thank you so much for joining in.
All right. I do have one question that came in. Can you hear me? Can you hear me, Dr. Davis?
Okay, so we do have a question.
Yes. Can the
does
link to this?
Pronamel toothpaste really work? So it does. Thank you, Lauren, for the question. It actually does. Some research has been done on it, and it does have a bit of an effect on the dentin tubules and helping decrease how sensitive they are in response to sensory input. That being said, you do need to use it for at least about 3 to 4 months continuously, day to day. And there's no guarantee that it will completely solve sensitivity by any means. However, it does show like statistically significant benefit. I use it myself, and I kind of recommend it for anybody that I come across that has sensitivity. And so far, I've seen a lot of positive feedback. Does in Now, Sarah, I'm not quite familiar. What is NHA toothpaste? Does that have a longer title? Or is that like a brand name? Nanohydroxyapatite. Okay. Huh. So now I will say I'm not personally familiar. That being said, I know that enamel is made up of a hydroxyapatite structure, and so I'm actually very curious myself. I will do a little bit of research on that, and I'll get back to you personally. I'll take a quick note of your name, or if you're able to pass along your contact information, I would love to get back to you on that one, because that does sound promising. Perfect. I'm writing down your email now.
Thank you all for attending today's
All right,
presentation.
perfect. And if anybody else has the same question as Sarah, let me know, or also give your contact information. So whatever I find, I'll pass it along to anybody that's interested. That being said, do give me a few days, but I certainly will get back to you.
For those of you that asked about a certificate, we will be able to provide these once you reach out to Courtney Pierce via email. She will be able to send you a certificate of attendance. And for those of you that are requiring CE certification, she can send those out as well. So thank you once again for attending today's call. We'll be sure that Dr. Davis follows up with all of you. We have email addresses for Lauren Sachs and also email address for Miss Rosenquist. Thank you once again for attending today's call. We truly appreciate your time, and we truly appreciate your effort in being able to be another attendee for our training today. Thank you so much and have a great day.